Hi there everyone, it's Sarah from BJC Health here. Thanks so much for tuning in to another one of our educational events. The presentation you're about to watch is all about Sjogren's Syndrome. So it's presented by one of our rheumatologists, and we're looking forward to, taking you through what the condition is, some of the challenges that are faced by those who have this condition, as well as hear some questions and some things that are raised by our audience that were there live with us on the night. So enjoy part one of this presentation. If you'd like to watch the whole presentation, please consider signing up for BJC Connect. That's where we keep all of our presentations in their entirety, and it also allows you to access all of the live educational events that we host each and every week. But for now, enjoy part one, and I hope you find the event useful.
Welcome to tonight's event, everybody. My name is Robin. I am an exercise physiologist at BJC Health, and I'm going to facilitate tonight's event with Fabio. So Dr. Fabio Kullock is here tonight to talk to us and enlighten us and share his knowledge about Sjogren's Syndrome. And I had to say that word a few times tonight because it can be a tricky one to say, but Sjogren's Syndrome, which I'm sure some of you here are very familiar with and have said it numerous times. But please welcome, just some housekeeping before we get started. We'd like everyone to just stay on mute tonight, just so that the sounds don't interfere, but we do really want to hear from you. So please use the chat box, pop your comments in there, pop questions. We want to hear your experiences, so it doesn't just have to be questions. And yeah, tonight Fabio is going to share a presentation with us, but we'll have a bit of a chat and a discussion, and there'll be plenty of times for questions. So please do pop them in there as we go. If you've got any, even right now, pop them in there so we know that we can try and answer them for you. So yeah, let Fabio take it away. Here we go, Fabio. You can go ahead and share your presentation as well, and hopefully we'll all be able to see it.
All right. Hi, everyone. Good night. As Robin said, my name is Fabio. I'm a rheumatologist at BJC. I'm going to discuss a little bit about Sjogren's disease, Sjogren's syndrome, which is a disease that a lot of people heard of it, but a lot of people don't exactly know what that is. So I'm going to go through a few important items. Oh, here it is. Okay. So first of all, Sjogren's is not just dryness. I know when people think about Sjogren's, they think about that picture, just dryness, and that's it. But there's a bit more to it. Sjogren's is actually an autoimmune disease, which means it's not just affecting the lacrimal and the salivary glands, but the dryness, that is the most common symptom, is usually caused by destructions of the glands. And this is going to have repercussions in the treatment, as I'm going to say a bit more to the end. And as an autoimmune disease, rheumatological autoimmune disease, there might be a lot of extraglandular, that means not dryness symptoms, which might include joint pain, fatigue, lung and kidney involvement, and a lot of other things that are a bit more rare. I'm not going to go through it. And this is one of the most important parts, an increased risk of lymphoma. This is one of the main reasons to diagnose this disease. Some studies actually suggest 44-fold increase risk of lymphoma. So we really need to be careful about this. How do we diagnose Sjogren's disease? First of all, we need the symptoms. Dryness, severe dryness. It's not just one of those dryness where you drop in the eye once or twice a day. This is recurrent 5, 6, 7 times a day. You need all the time. The dryness can affect the eyes, the mouth, and the skin. They're the most common sites of dryness, but many other parts can be affected as well. We use a few blood tests because it's an autoimmune disease, so we need to have evidence of autoimmunity, which means antibodies, autoantibodies, ANA, SSA, and SSP. Now, the important part here is to understand that you might have these antibodies, 3 of them, and you might not have the disease. The disease means you have the antibodies and the symptoms. We often use eye tests to confirm a low lacrimal production. I'm going to show you in a bit one of those. Some images can be used. Ultrasound and MRI are going to show the anatomy of the gland, if it doesn't show the functionality of the gland. Cialography, it's a very interesting exam. It's very difficult to find, but it's a very interesting one. You give the patient a special dye, which the gland will absorb. And when it absorbs, after a while, it's going to eliminate that dye. And we have this special sort of an X-ray that can detect this dye. So if the gland is not taking in the dye, that means the gland is not working effectively. If it is taking, for example, and it's not eliminating, there might be an obstruction. So it shows a few other things. Sometimes we might ask for a lip biopsy because we want to see inflammation of the small glands in the lips, but we only ask that in rare circumstances because there might be side effects. A lot of people remain with tingling or numbness sensation in that area. And if you only have dryness and no other symptoms, like I'm going to say a bit more to the end, there's not much we need to do. And we always need to exclude other causes. There's a lot of different causes for dryness. Now, this is the Sjorgen's test. In the picture, seems like a lady. She's with the eyes open, but it's actually made with the eyes closed. They put this little tape in the eye that has all the millimeters, and you keep that on with the eyes closed for about 5 minutes, and you're gonna see the tear going down the piece of paper. If it's above 20 millimeters, that's normal. If it's below 5, it's suspicious of Sjorgen's syndrome. What about anything between 5 to 20? Well, that's a bit of a gray area.
Fabio, can I just pause you there for a moment? And if you can just flick back to your diagnosis slide. And again, if anyone does have any questions, you can start to pop it in the chat, potentially about diagnosis. But I thought that was quite interesting, some of the tests in there, and I'm sure some of us on the call today probably don't have any idea what some of those words and the jargon can be. Would you mind, just for, I think, sake of understanding, just let us know what ANA, SSA, SSB are in terms of the blood tests and the markers that you might be looking for?
I haven't gone much into them because it's quite specific. ANA is an autoimmune test that it's very common on the healthy population, but it can be positive on the people with autoimmune diseases. ANA basically is a technician is going to put the special dye in the blood and going to see if it's shining. If it's shining, it means there's a lot of antibodies in the blood. Those antibodies might be causing your disease, might not be causing your disease. We don't usually recommend them to be done as a trial because, like I said, they can be normal in the healthy population, but it's very helpful for us to diagnose because if it's negative, the likelihood that you will have an autoimmune disease, rheumatological, as in Sjorgen's, it's very low. SSA and SSB, they're specific antibodies that are usually associated with Sjorgen's. They can be positive in other diseases, but there are specific antibodies for Sjorgen's.
And would these typically be tested by your GP, or is that something that, once the person comes to you, that's what a rheumatologist might order?
It's quite commonly requested by the GP, and it's often a cause of confusion because, like I said, they might ask for that for a completely different reason, and then it's positive and they're not sure why. And sometimes it's just not related. It's what we would call a false positive, a positive antibody without a disease. We usually recommend them to be requested by a rheumatologist, but it's very commonly requested by a GP.
Right. And I think you said, obviously the blood tests are one thing you look at, then you might do eye tests and some other imaging and biopsies. Would you typically do all of those tests to confirm, or say the bloods come up positive and you do the eye tests and it's above 20 on the next one you showed us? Would that be enough for you to confirm, or do you really try and make a thorough?
Actually, it's the opposite. For the diagnosis of Sjorgen's, it would be below 5. But if the patient has a lot of dryness, and like I said, using drops 4, 5, 6 times a day with a very positive ANA, SSA, and SSB, that might be enough for diagnosis, especially if they have extra glandular symptoms, which is going to be even more suggestive of Sjorgen's. But often the dryness, and most commonly, to be honest, the dryness isn't that severe. We like to get it early on, this disease. So sometimes you need the eye test to confirm there's actually a reduction on the production of the glands. One reason, for example, that you can have dryness, I'm talking about reduction of production, but if you just, the tears are just evaporating too quickly, you're going to have dryness as well. So this test, it's going to be important to make sure it's a low production and not evaporation or any other thing.
Right. Interesting. There's been a question about a nail fold test. Is that something you're aware of or would use to diagnose?
Yeah, nail fold test is actually much more specific to another disease called systemic sclerosis. It can be positive on Sjorgen's disease, but there's no study suggesting that's going to make it more likely or less likely for a diagnosis. So we do not use that for diagnosing Sjorgen's disease. It can be used. One of the extraglandular symptoms are manifestation in the skin called Reynolds phenomenon, which is an abnormality in the blood vessels in the hands, and nail fold can detect that, but that's an exceptional circumstances. We don't usually use that on a daily basis, not for Sjorgen's, I mean.
Excellent. All right, I'll let you continue where you left off, Fabio.
So other causes of dryness, we have a lot of diseases that can cause dryness. Thyroid, both increase and decrease thyroid can cause dryness. A few infections can do that: HIV, hepatitis B, hepatitis C. Rheumatoid arthritis can cause dryness. There's a lot of other causes for dryness, and we always need to exclude them. A lot of medications can cause dryness, most importantly, diuretics and antidepressants. Any antidepressants can cause dryness, but the most commonly associated with dryness is one called amitriptyline, with the commercial name of NDEP. That's the most common one. Age, unfortunately, with age comes a few other complications. For example, we just lose functionality of the glands. Contact lenses is something we forget to ask often. If you're using contact lenses, then the tear doesn't actually go sometimes through the eye, it just goes straight to the other side. So you feel dryness because of that. And history of radiation is, if you had any cancer in the face or in the neck and you've done a lot of radiation, it can have destroyed the glands.
Very interesting that there's quite a few things that can cause dryness. How would you typically figure out what it is? Would you do an elimination of something? And yeah, potentially if someone might have another disease and they've got contact lenses, what do you do to figure that out?
So when a patient comes with dryness, I always request those infectious diseases. I'm just looking for them. Honestly, I've only seen that happen once, but I always look for them. If you don't look for them, you'll never find it. Having excluded that, I'm going to see the antibodies. If a patient has a lot of dryness and a lot of antibodies, then even though they might use an antidepressant, they might still have Sjorgen's. But if I'm not finding anything, I'm going to go ahead and get a very thorough history and just trying to eliminate any antidepressants, diuretics, or whatever might be causing, if possible. Sometimes a patient has a severe depression. You can't just remove the antidepressants.
Right. And how long would you potentially, and the answer might depend on the type of maybe medication, would you get them to trial stopping it for?
It's usually almost instant. You stop the medication within the first week, you usually get an improvement of the symptoms.
Right. There's some specific questions here, and if you can answer, but does Lyrica specifically cause dryness, and antihistamines as well as a separate?
Antihistamines definitely are amongst the possible that can cause dryness, yes. Lyrica does not usually cause. If you take a look at the patient information, that might be something about dryness, but it's not something I commonly see. It's one of the safest ones, but it's not an antidepressant. It's a different class of medications.
Yeah. We've had someone in the chat also confirm from personal experience that their antidepressant causes dry mouth as well. And she has RA, so that sounds, quite typical is what you've mentioned. Something to talk about with the contact lens, I suppose. Someone's commented here, do people who have artificial lenses after cataract removal have dry eyes? Is that something
No,
common?
that's different because that's put underneath the eye. The contact lenses, it's put above, over the eye. So it makes all of the difference in the world. Only the contact lenses you use for any day-to-day eye things, eye problems.
Right. Awesome. Thanks, Fabio.
Can I go ahead?
I'll let you continue.
So how do we manage Sjorgen's syndrome? I guess most of you are here to understand how to manage this. Unfortunately, there's no medication that can provenly slow down the gland's destruction. So the treatment for the dryness is going to consist on treating the dryness itself, not slowing down, not giving you immunosuppressives to reduce the dryness or anything like that. The only reason we would treat something else would be if you have extra glandular symptoms. Now, how do we treat the dry eyes? First of all, and this resolves a lot of the cases, modifying the environment. So limiting time at computer, reading, or driving. Why does that make a difference? If you're in the computer for too long, watching a class about Sjorgen's disease, for example, or reading about Sjorgen's disease, or driving truck drivers or anything like that, you don't blink. So the less you blink, the drier you get. So if you limit that time, you're going to be blinking more, and then that's going to make it a bit better. Trying to install humidifiers, as I have here on the screen. I usually recommend having two, at least one in workplace and one in the house. So you keep the ambient as humid as possible. That's going to prevent evaporation of the tear. And avoiding air conditioning and even heating. So if you can avoid both of them, both air conditioning and heating.
I can't hear through these.
Someone's with the audio. Both air conditioning and heating, they can dry the ambient. Cease the medications if possible. Like I said, I'm not going to ask anyone with a severe depression or a heart problem to stop diuretics or to stop antidepressives. But if possible, you should try to cease it. And this is really important. Avoid nicotine, avoid caffeine and alcohol. Omega-3 and flaxseed oil, they're very controversial if you look at the literature. But honestly, I've had quite a bit of an experience with a lot of patients with both of them, and it works. A lot of people have a lot of improvement by using either one. Personal opinion, flaxseed oil tends to be a bit more effective, just personal opinion. Obviously, you can use lubricant ointments and eye drops, but they're usually short-lived. You get a drop in the eye, it's going to get better within a half an hour, and after 1 to 2 hours, it's going to get dry again. So everything above that is much more important than the eye drops themselves. This is a very interesting one, punctal occlusion. I'm going to explain what that means. We produce the eye in the outside of the eye the tears in the outside of the eyes, and then the tear will go to the inside of the eyes, and it's going to go through the nose. What we can do is occluding, is just shutting down this duct in the nose, so the tear won't flow away. It's going to remain in the eye for longer. There's only a few indications to use that. The best person to do that is your ophthalmologist, but the patients that I've had that tried this, it really helped them. What is the plug? The plug is a temporary solution to see if it's going to work for you. They put a silicone plug here, and if the symptom improves, they can make it a definitive solution.
Cool. Can I pause you there, Fabio?
Yep.
Very interesting. I've got some questions, but again, I will read some from the chat as well. But when you talked about avoiding nicotine, caffeine, and alcohol, was that a direct relation to what can potentially cause dry eyes, or does that have any relation to the gland itself?
They all can reduce both tear and saliva production. So if you're using those, you're going to be drier. Caffeine and alcohol, for example, they are diuretics. So if you drink a lot of caffeine, you're going to be peeing a lot more than if you're drinking water.
I'd love to hear from anyone here tonight if you've had some personal experiences and you've noticed you've maybe seized something, or you've tried any of these, or you've got any other treatments that you've tried for dry eyes that have worked. It'd be really great to share with the rest of us here tonight. Your last comment there about the ophthalmologist, is that something you would typically recommend that someone with Sjogren's and dry eyes see, or unless they've got other eye issues that they happen to be seeing them for?
I usually like my patients with Sjogren's to have a regular ophthalmologist for a routine checkup, making sure there's no damage to the cornea, because there are some damages from severe dry eyes that can cause infections and other complications. So I usually like having a regular ophthalmologist on the same page. When I say regular, I don't mean like going to the ophthalmologist every 3 months, but someone that knows your disease and knows you. So if you have any complications, you can go straight to him.
Yeah, that's some great advice. Your point about omega-3 and flaxseed oil, and we know it's controversial, whether it's based on research or what you might have found from experience, what dose of flaxseed oil would you recommend if someone were to try?
Both doses from omega-3 and flaxseed oil is up to 3 grams a day. But that's just what's on the patient information on both of them. There's no right or wrong dose for dry eyes. Unfortunately, the studies, they don't mention the exact dose because it's very difficult to do a study with that. Since it's a very, very broad symptom, very non-specific symptom, it's very difficult to measure how much of an improvement you have. So it's very difficult to say that 2 grams is better than 3. It's very difficult to do studies with it. This is why it's not actually proven, because of the difficulties doing studies.
Yeah, very tricky with the studies, but good to know that it's there's someone in the chat here who said that they use high dose fish oil, 6 capsules a day, with some positive results, and don't know what other factors might be coming into play, but
be careful about the 6 capsules a day, because I'm taking omega-3 and my capsule is 1.5 grams. If you're taking 6 capsules a day, it's probably the 500 milligrams one to make 3 grams a day, just so that everyone don't go to the grocery, to the pharmacy and buy 1.5 grams and take 6 tablets a day. It's going to be too much.
Yeah, I think it's important to know that every brand, every bottle that you see, there could be different doses. So maybe capsules might not be the best way to quantify it. There was a question earlier, and I'll just ask it now in relating to the eyes. Does having a history of uveitis or iritis relate to Sjogren's, or is there an increased risk of?
No, it's 2 different things. Uveitis and iritis is an inflammation of the eye itself. Sjogren's is an inflammation of the glands. If there is inflammation in the eye, it's only because of the lack of tear, not in direct inflammation of the eye. So that's 2 different things.
Awesome. Just some comments here. Someone has used plugs and used the lubricant ointment every night, so hopefully that's working for you. And someone here says that they've got dry eyes, so that obviously fits the criteria potentially for Sjogren's, but a burning pain and needing to blink constantly. Is that something that's also quite common?
Yes, burning is one of the symptoms described when we think about dryness. Some people, instead of describing directly dryness, they describe burning. And blinking, every time you blink, you're bringing tear from the glands to the eye. So your body just feels like you need to blink more because it's dry.
Excellent. All right, I'll let you continue. I'm sure there's lots more we want to hear.
So there you have it. That was part 1 of Sjorgens Syndrome and our discussion on that particular condition. If you'd like to continue watching the presentation, then please consider signing up for BJC Connect. The details are on your screen now. It's our free online platform where you can access not just part 2 of this particular event, but all of our live events, as well as some of the recordings that we've done in the past. So thanks for watching. Hope you found it useful and look forward to seeing you again online soon.